Welcome to the Obesity Matters Wellness Workshop, where we embark on an incredible journey towards better health and wellness together. Whether this is your first time or you've been with us since we started, we are grateful you are here. My name is Rachel. I am the Vice Chair of Obesity Matters and your host for this year-long program. Today's topic dives into yet another tool that's available to help us on that journey. I am thrilled to welcome Dr. Amy Rothberg and Dr. Judy Loper to guide us through today's session, and the title is Shaking Up Nutrition, Navigating Meal Replacements.
Thank you, Rachel. We're very excited to be with you, and I want to thank the organizers for this event, and specifically also Dr. Zimke and Dr. Novik for inviting us to lead this discussion today. As you know, we're going to be talking about total diet meal replacement, or we just refer to it as total meal replacement, or TMR. So I want to propose this. What if there were a dietary intervention that reduced hemoglobin A1C? And for those who do not know what a hemoglobin A1C is, that is the average over 90 days typically of blood sugar, and it is given as a percent. So if this dietary intervention were able to reduce A1C by 1 to almost 2%, while other diabetes medications were reduced in dosage or completely eliminated. Also, if it led to a 10% or greater decrease in body weight and reduced blood pressure, the top number by 6 and the bottom number by 4, and lowered one aspect of bad cholesterol called triglycerides and raised the good fraction of cholesterol, that is HDL cholesterol, protected the kidneys, improved obstructive sleep apnea, improved our ability to get around, and also reduced pain and improved quality of life. So let me just switch gears for a minute and talk a little bit about background of TMR. So as I think we all understand, weight loss does require an energy deficit, and that's usually achieved by reducing the amount of calories consumed in a food-based diet. Food-based diets typically average about 4 to 8% loss of initial body weight. Total meal replacement is the use of meal replacements as the only source of daily nutrition. And MRs can be used as part of very low-calorie diets or low-calorie diets and are recognized by international guidelines as components of weight loss programs, contributing to weight loss, a nutritionally balanced diet, and long-term weight control. So let's just define what we mean by a reduced calorie, low calorie, and very low calorie diet. A reduced calorie diet is one in which the calories are reduced to about 1,200 to 1,500 kilocalories per day for women and 1,200 to 1,800 kilocalories per day for men. A low calorie diet comprises more than 800 up to 1,200 kilocalories per day, and a very low calorie diet is one in which we're consuming 800 or fewer calories per day. And here I'm showing you graphically the primary outcome. That is, again, the percent weight change from baseline at week 26 here on the left side and week 52. At 26 weeks, the reduction was 12.5% in the TMR group compared to 6% in the food-based group, so that amounted to almost a 6.5 percentage point difference. And at week 52, in the TMR group, 10.5% reduction in body weight compared to 5.5%, or a 5% reduction.
Well, I'm just going to back up a little bit before I start my talk too. We do know we're talking about meal replacements, but if you go way back, actually there's been a lot of research even before the study that Dr. Rothberg presented, going back to the 1970s. So meal replacements really started being looked at back in the days. And back in the days, they called it a protein-sparing modified fast, supplemental fast, very low-calorie diet, and now we have what we call meal replacements. But if you want to look at the literature, you'll need to go back and use that verbiage to find out kind of what the research was back then. And I originally actually did my PhD work back in the early 80s on meal replacements, body composition, and so forth. So I've been working with them for 45 to 50 years. So I'm going to give you my perspective here. But these are some tools I'm going to share with you. Of course, the one that comes out in all the literature is exercise. The unfortunate thing is if you do have a patient who's elderly, who can't do the exercise, they really need help to do small amounts of exercise to get started. So that's so important. Another thing that's come out all the time is self-monitoring. In the olden days, and I had one of my patients in this morning, he uses paper and pencil to track everything that he does. Yeah, I've got a handful that still do that, but everybody else has smartwatches and all these things. But self-monitoring is so important. The other thing that Dr. Rothberg talked about is, look, pre-planning your meals and snacks. We're in a very busy world now where people are working, raising a family. How do you have time to really do this? So it takes a lot of maybe pre-planning on a weekend to get everything ready for the week for your meals and snacks. Number 4 up there is goal setting. You may not stay exactly at the number that you've achieved during weight loss, but maybe there's a goal range that you want to stay within. So you need some goals. Oh, this is really what's comfortable for me. And it's not a high school weight or anything like that. It's a weight that you're healthy, that you feel good, and that you can do, your quality of life is improved. The other one, of course, that's related to weight, you read all the time, is adequate rest and sleep. So important in terms of long-term weight management. And it goes along with the stress management. Realizing, what you can do to keep your stress levels down so that you're not turning to food to deal with all of this. So it's a lot more than just the physical part of it, but all the mental part that goes as well. Accountability. Like I said, our clinic's been here for 45 years this March, and I'm still seeing patients I've seen for 10, 15, 20, 25 years. A strong support system. We have the support system here at the clinic, but we want to make sure they have a support system at home as well. Now, of course, we've been clinical sites for some of the anti-obesity medications, and there's some newer ones out now. So that's another tool to help some of these people long-term. A meal plan may be altering macronutrients, like Dr. Rothberg was saying. Sometimes in maintenance, we will maybe look at keeping their fat intake down. And I think that was in either Look Ahead trial or the National Weight Control Registry, where those patients who were successful were eating a low-fat diet. So we might have to adjust those as well. Intermittent fasting is the latest one out, maybe 10 years old when it was first researched at University of Illinois, and that works for some people. They like to have time-restricted eating where they only eat between these hours, or they're more restricted during the week than they kind of eat what they want on the weekend. And that works for some people for weight maintenance. For weight loss, it might not show as much, but it might be another tool that they can use in long term. And then we have, of course, what we've always used are the meal replacements. And we found them not just valuable for weight loss, but long-term weight maintenance. And the gentleman I had in today that I said lost 33 pounds, he uses a meal replacement 1 or 2 times a day. So I just put up here an example of a meal plan. I didn't put calories or anything. And again, it'll vary from person to person. But again, for breakfast, a typical idea might be a patient might have a meal replacement 1 or 2 for breakfast, a regular lunch they might have, and then maybe nuts and yogurt mid-afternoon, dinner, maybe fish, vegetables. If they are going to have some extra carbohydrate, maybe the potato, and the evening yogurt or fruit. Or some people like to have the meal replacement at lunch because they eat breakfast at home and they eat dinner at home, but they have the meal replacement at lunch because it's so easy to take with them.